and turn it over to Rebecca to do our introductions. Thanks so much for joining.
Great. Thank you so much, Samantha. And thank you everyone for joining us today for our monthly REAIM seminar. So we're really, really excited today to be joined by Dr. Jennifer Lewis and Dr. Lucy Spalluto. So I'm just going to read their brief bios and then I will turn it over to Jennifer and Lucy, and we'll make this really interactive. So if you have questions, please feel free to put them in the chat or raise your hand, however you want to do it. And we can answer questions as we go along, or certainly when we get to the end, there will be time to ask and answer questions, because I know that both Lucy and Jennifer have questions for all of you. So really looking forward to this session. So Jennifer Lewis, MD, is an assistant professor in the Division of Hematology and Oncology at Vanderbilt University Medical Center, where she focuses her clinical practice on the care of patients diagnosed with lung cancer. Dr. Lewis is also a staff physician at VA Tennessee Valley Healthcare System and co-directs their lung cancer screening program. She is currently in the VSTTAR K-12 program at Vanderbilt, and her research program focuses on translating lung cancer early detection and prevention into clinical practice. She's leading a national evaluation of lung cancer screening programs in the VA and studying behavioral factors that influence providers' lung cancer screening practices at VA and Vanderbilt. Dr. Lucy Spalluto, MD, is a professor of radiology and radiological sciences in the breast imaging section at Vanderbilt University Medical Center. She serves as the department's vice chair of health equity and as an associate director of diversity and inclusion for the department. Dr. Spalluto is co-chair of the Radiological Society of North America's Health Equity Committee. She is a member of the VA Tennessee Valley Healthcare System Lung Cancer Screening Program Steering Committee. Dr. Spalluto leads an active research program to address disparities in lung cancer screening and breast cancer screening through an implementation science approach. Thank you so much for being here, Drs. Lewis and Spalluto. I'm going to go ahead and hand it over to you.
Well, thank you so much. I'm Lucy Spalluto, and
I'm Jen.
And we're going to be kind of going back and forth during the presentation, but we wanted to start by just thanking all of you for the invitation, and a big thank you to Thomas Strayer for connecting us and being really a critical part of our team in this work, and we wanted to make sure he was recognized too. I'm going to share our slides. Okay, can everyone see? Okay,
Yes.
If there are any technical difficulties along the way, please don't hesitate to speak up. And as Rebecca mentioned, if you have any questions during the presentation, please speak up, put them in the chat. Rebecca, I can't see the chat. I don't think so. If you see any, just let us know, flag us.
Will do.
But we're delighted to have this be more of an open conversation, and we really have been looking forward to the feedback from this group. This has been really a labor of love working on this project for many, many years. And as we sort of developed a lot of our measures and plans, we had a lot of discussions about how to do it the right way. And so we are really excited to have this team give us feedback on, opportunities for improvement. So please, we are looking forward to your feedback. So we're going to be talking about using REAIM to evaluate lung cancer screening in the Veterans Health Administration. Brief disclosures and a huge thank you to our funding sources, including the VA Office of Rural Health, the VA Lung Precision Oncology Program, and several other sponsors as well. For an overview, we are going to start by just providing a little bit of clinical background on lung cancer screening and the VA PALS program in general. And we'll talk about our use of REAIM in the development of the evaluation for VA PALS, where we stand with current results, and some of the challenges that we've encountered along the way, and close with talking about future directions. So we have had quite a journey in our VA PALS program evaluation. Jen and I actually were randomly assigned to be office mates at the time of our VA Quality Scholars Fellowship. I think that Dr. Robert Dittus, who oversees the program, knew that we had a lot of similar interests and maybe paired us in the same office. So Jen is an oncologist and I am a radiologist, which is kind of a unique pairing to work together. But in the world of cancer screening, it really was a very natural relationship to work together and the early diagnosis to the early treatment stages of cancer screening and diagnosis. So we met in the VA Quality Scholars Program and went through our Masters of Public Health together, started working in implementing the local lung screening program at our VA, and then began to make these connections. So this is us with Harold Thompson, who is the chief of radiology at our VA. And then we met some folks on the national level, Drew Moganaki, David Yankelevitz in the bottom right picture, people who were really involved in lung screening nationally. And then we forged these relationships and started working with the program evaluation for a national program that was implementing lung cancer screening across 10 VAs across the country. So quite a journey that we've had a great time on. So a little bit of background on lung cancer. Lung cancer is the leading cause of cancer death. If you look at the number of lung cancer deaths compared to the next 3 highest cancers combined, the number of lung cancer deaths is higher. So higher than colorectal cancer, breast cancer, and pancreatic cancers combined. So there is a lot of room to improve here. We need to start addressing why lung cancer remains this leading cause of cancer death and how we can make some clinical improvements there. What else do we know? We know that low-dose CT is a way to screen for lung cancer and has been proven to reduce mortality in the high-risk population. This has been proven by several large national and international trials. So the first big trial was the National Lung Screening Trial, which showed that low-dose CT demonstrated a 20% reduction in lung cancer mortality when compared to chest X-ray. So it works. We know that this is an evidence-based practice that people should be using, but we also know that they're not using it. There have been additional international trials like the Nelson trial that showed a 26% reduction in high-risk men. So lots of trials have shown that it works. We know that we're not doing it. And so this is sort of the implementation science gap to address. So how does lung cancer screening actually work? What does the process look like? So again, I said I'm a radiologist. To me, it seemed like at the beginning, this seems pretty easy, right? Like we get a CT scanner, we put the patient in, we do the scan, the radiologist interprets it and gets the result. What's so hard about it? Why are we having a hard time getting this done? Lung cancer screening is much more complex than just having a patient get a study and having a radiologist interpret the result and give the result. Lung cancer screening requires a discussion between a provider and a patient about the risks and benefits of lung cancer screening, a shared decision-making conversation. So in order to get reimbursement through CMS, you have to have this shared decision-making conversation. It also requires having a discussion about potential options for discussing tobacco cessation. And this doesn't mean that patients have to quit smoking to get lung cancer screening. It just means your program has to have opportunities available to have this discussion, and for patients who are interested in pursuing tobacco cessation, opportunities for different ways to do that. You also should have a group of experts who can discuss complicated cases and what you might want to do with those cases. So it's not as easy as do the scan, shows cancer, doesn't show cancer. It's do the scan, there's a finding that's kind of suspicious in this patient who has these other risk factors or these other comorbidities. Is that something we want to pursue? Do we want to watch it? Do we want to go ahead and biopsy it? You also need to have a large type of subspecialist available for potential for treatment. So you might need to have trained interventional radiologists who could do biopsies by image guidance, trained pulmonologists who could do the biopsies by bronchoscopy. Then you need oncologists for medical oncology treatment, surgeons for surgical removal. So it's a big team of people, and it's very complex as to how you're going to implement this in your own clinical setting, whether it's at your one VA setting, if you're in a hospital setting, if you're whatever your setting might be. It's very unique how you might approach putting these programs together. There's also a lot of complex policy surrounding the use of lung cancer screening. So the current USPSTF recommendation as of 2021 for those who qualify for lung cancer screening, it's those between the ages of 50 to 80 that have at least a 20-pack year history of cigarette smoking and either currently or formerly smoked cigarettes within the past 15 years, are asymptomatic and would be able and willing to undergo curative treatment. So we've put those words in red regarding the smoking history. It's very hard to gather smoking history from an electronic medical record. So I do a lot of work in the breast cancer arena too. Very easy to know how old someone is, to know if they qualify for breast cancer screening, you know. Although there are different guidelines as to when you might want to start them, you could put a flag in that says, you know, every woman age 40 and older recommend a screening mammogram, or for colon cancer screening. But this is really hard to get this piece of smoking history. CMS offers coverage for a similar population. The VA policy is to follow USPSTF, but ultimately leaves decision-making up to resources and policies at each local VA. So that's about lung cancer screening and the policies surrounding lung cancer screening. What is this VA PALS program? Well, VA PALS is an enterprise-wide initiative by the VA to start to offer increased access to lung cancer screening, really focused on rural populations because a lot of the funding came from the Office of Rural Health. The goal was to start lung cancer screening programs at 10 sites. This initially started in 2017. And the original 10 sites are denoted by the little stars on this map. So spread around the country. This program was designed to offer, to help hire a navigator at each site, so a program navigator, to develop and install a comprehensive electronic management system, to offer some quality control for the CT scanning, the imaging scannings, and to offer a support network. So to provide education, training, an opportunity for questions to be answered, to offer support. How this was actually done was left up to the individual sites.
I will say too that the funding for the navigator was just temporary for the first 2 years, funded by the Office of Rural Health.
VA PALS has grown over time. Some sites left and some new sites joined. And as it grew, it really became this collaborative learning network where different sites were working together, navigators were asking each other questions, radiologists could ask each other questions. And so this learning network was really cool to see it grow and change over time. And so what did some of these offerings look like? There was facilitated navigator training for up to 15 sites over time, because as we said, the original 10 sites increased and changed over time. This navigator training looked like they could come to New York to a central hub where there were experts and do an original training. They had monthly roundtable calls where they talked to each other about program or about difficulties they were having, how some had overcome those difficulties. There was a newsletter that was distributed about the different ongoings and a website with information. What did this software system, what was it intended to look like? This was based on an existing system called ILCAP that was developed by experts in New York and used this system at multiple sites around the world. And they offered the code and sort of what the system looked like to be built into the VA system. This is going to be called the VA PALS LCAP management system. It's open source. It was supposed to be implementable into Cerner, the VA's electronic medical record system. It's going to be adapted with VA clinician input. And it was going to be the sort of central data collection hub. And the centralized quality assurance, this was to improve radiologist quality of scan reading, the scanner quality, the actual image quality, and to look into procedural or complication monitoring for patients who had procedures. We developed a logic model for the overall program, looking at the different inputs, people and technology, all of the activities, and I'll go into this in a little bit of detail on the more slides, and the outcomes, of course, is where we used a lot of re-aim. For the outcomes, and when this is something we talked about a lot, we know that traditionally 12-month window is used for sort of the short-term versus long-term outcomes. We had a lot of trouble getting this program going initially. And so
we ended up changing it to 24 months just because the logistics of getting the navigator hired and then working out the different processes at each VA, we would have like not a whole lot in adoption otherwise.
Right. So that was sort of an on-the-fly decision that was made here, and we wanted to make sure that we pointed that out. So program inputs, lots of people. So as I talked about before, in order to do lung cancer screening, you need people from all of these different specialties. And so the leadership team for VA PALS included experts in clinical work, radiologists, radiation oncologists, pulmonologists. There's also IT experts and the software team, and we were part of the program evaluation team. And then there were all the local teams at all the different sites, which included local champions, the navigators, all of the other providers, the support staff, and the local VA leadership at each of the different VAs. The technology included the management system we talked about, the actual CT scanners, and CT Phantoms, which are a quality assurance tool for the CT scanners. What did some of the actual programming look like? Sorry. We talked about some of the support network, the calls, the roundtable calls. There was supposed to be a written guide to lung screening. I don't think we had ever came to fruition, but there were lots of support network resources. The actual acts of the clinical lung screening, how to recruit patients to do those shared decision makings and offer the smoking cessation, the actual act of doing the screening, and then all of the downstream follow-up needed for either normal screening or abnormal screening. Data collection, developing the intended tool, the VA PALS LCAP tool. The VA corporate data warehouse is the VA's usual data collection tool, where the data is housed regardless of developing this other system. All clinical data for the VA is in there. And then some extra ways to collect data, including performing surveys with different individuals involved with the programming and in-depth interviews. All right, so as we were developing our program evaluation for VA PALS, we used the CFIR as sort of our overall guiding model to make sure that we weren't forgetting any aspect of the program or lung cancer screening to consider. So we thought about, things in the inner setting, all the different individuals and teams at each VA and within the leadership, the inner setting of what it's actually like to work clinically at each VA, the actual process of lung cancer screening, the actual process of the evidence-based practice. And then we thought about the outer setting of the VAs, of the VISNs, which are the different groups of VAs in different areas, and then the bigger overall VA and policies that might influence that. And then started to think about how we were going to measure all of our different measures of implementation, and then how we're going to measure our final outcomes. We also used the framework as we looked at adaptations, and this was something that was actually not a part of our original program evaluation, but as we started looking at a lot of process maps and changes over time, we turned to the framework to capture those. And Thomas was a really big help with this portion of the project. And then we used the REAIM framework to develop the actual measures. And so for the next part of the talk, we're going to go into a little more detail on each section of REAIM and how we developed measures and where we currently stand on those outcomes.
Okay, so starting with REACH, we were really excited, I will say, in planning our REACH measures, because we wanted to look at REACH throughout the entire process of a veteran coming to the program to the point where they got their screening. So this included starting with an estimate of the number of eligible veterans for lung cancer screening, and then looking how they were coming to the programs. Were they coming through referrals from providers, or were they coming from direct outreach by programs, or even just an order that was placed in the chart for a low-dose CT scan? So of the veterans that came to programs, how many were approached and we were able to get in contact with, how many we weren't able to get in contact with. We were also interested in looking at, of those that we reached or that we contacted, how many were agreeable to screening, how many declined, how many were undecided. And then of those that were agreeable, how many actually got an order? And then of those that got the order, how many got the actual screening done? So we even built these measures into the VA PALS LCAP management system. And these are kind of some examples of how we did that. So we got the method of program entry up at the top, and this is kind of a mock patient and what the VA PALS LCAP system looked like. And then this one down here was capturing approached and whether they responded or not. So I will say that a lot changed over the course of VA PALS program, and this will kind of be a theme throughout the presentation. But the VA PALS management system was not ultimately installed across all the VA PALS sites as it was originally intended. VA Central Office decided to go with a different management system, in around 2021. And even though this one had been successfully adapted, it was installed at the Phoenix VA and was pilot tested and then installed at Nashville, and then even got approvals to go into the VA's enterprise cloud. It was not ultimately used across the VA PALS sites as originally planned. But kind of luckily, at the same time that we got initially involved in lung cancer screening through VA PALS, I was doing some of my MPH work and using the VA's corporate data warehouse to evaluate baseline screening rates across the VA. So we kind of pivoted for a plan B to get our measures, a lot of which, for REACH, from the corporate data warehouse, which is the large administrative database that captures billing codes as well as data from the electronic medical record. So we built a cohort of veterans screened based on CPT codes that were specific for lung cancer screening, but there was one that was not specific for lung cancer screening. So I didn't know how this was all going to work at first, but working with our national radiology office, we figured out that we could get the exam descriptions for those CPT codes. And so what we were able to do is to look at just the likely screening exams, those that had lung cancer screening in the low-dose CT CPT code, or they had LCS. And so that was one way that we were able to get down to these are the likely exams. And then after further exclusions, we got to a cohort of a little over 80,000 veterans screened with low-dose CT for lung cancer between January 2011 and May 2018. And we did some local validation, found our algorithm had a positive predictive value of 92%. So we used this cohort to then look at annual rates. So these are average rates of initial screenings per 1,000 eligible veterans. And so another issue that we've had that Lucy kind of alluded to is our denominator and trying to get screening rates. So it's hard to get to that pack year data and when they quit if they formerly smoked cigarettes. So luckily though, the VA did a demonstration project back in 2013, 2015 that gave us kind of the percent of age appropriate veterans who met those smoking criteria for lung cancer screening. And that was 32%. 32% of age appropriate veterans for screening met the smoking history criteria. So that's what we did. That's what we used. We got the age appropriate veterans from 55 to 80 at the time. And for each medical center for each year, and then multiplied that by the 32% to get our denominator for our rates. And so what you see here is that the rates of screening increased over time, especially around the policies, the USPSTF and the CMS policies that came into play. But really in 2018, only 30 veterans per 1,000 eligible, or 3%, were being screened. And this is similar to other rates at the same time in other healthcare systems. We also looked at average facility rates across VA, and we saw, so these again are per 1,000 eligible veterans, and we saw that screening rates over time increased throughout VA, but were more so in the Northeast and down in Florida. So we used kind of these methods to get our REACH measures, which we've been reporting out for the last few years. So we've been looking at the average number eligible by kind of the method that I just described. And then we've been looking at total exams. So this would be initials plus subsequent screenings. And then we've been looking at unique veterans screened across the sites. And these were all based on the previous USPSTF criteria. We've also been gathering demographic information on veterans screened by VA. So their age, their gender, race, ethnicity, rural status, documented tobacco use in the chart, which in this table was preliminary work that we've improved. And then coronary artery disease, COPD, comorbidities that are common in this high-risk population. And then we took kind of a deeper dive in looking at rurality, our our rural reach of VA PALs, and this is work that Lucy led. So we looked at veterans who were screened at the 10 VA PAL sites. And our exposure was rural status by RECA codes, and working with our Office of Rural Health really helped us to get the rural status. And then our primary outcome was annual repeat. So we really wanted to kind of look at that 12 months, did they come back to us? So our window was 9 to 15 months, but we did do a sensitivity analysis around 1 to 18 months. And we even did some subgroup analyses around age 65, less than 65 and greater than 65, and some exploratory analyses around initial screenings. We did logistic regression models and adjusted for multiple variables. And what we found is that throughout our analyses, there were lower odds of repeat screenings among rural veterans in our primary, our sensitivity analysis, and our subgroup analyses. And we recognize that these confidence intervals are wide, though. But in our exploratory analyses, we found even lower odds of initial screenings among rural veterans. And so this became, and the confidence interval is much tighter. So this became one of our key findings from the program evaluation so far. So I kind of described to you some of the challenges and how we've addressed our denominator issue, but we were thrown another curveball with the USPSTF 2021 expanded criteria that went to starting at age 50, it was previously 55, and then the PAC years went from 30 PAC years to 20 PAC years, still with 15 years since quitting. So we kind of went back to our leadership team, we went back to our mentors, our advisors. We're like, okay, how do we address this? Because our denominators changed in the middle of our program evaluation. And so we decided, and we talked to our sponsor, we talked to kind of like our program manager at the Office of Rural Health, and we all decided to come together and do a survey, and that this would be really informative to VA to find out what is the new eligible population based on USPSTF 2021. So we did a survey. It went out across all of VA, not just the VA PAL sites, and we collected information on demographics, other components of medical history that are risk factors for lung cancer. We even asked veterans about their awareness of lung cancer screening, whether they self-report being screened, and interest in abnormalities other than lung cancer. We piloted this in person at Nashville, VA, to kind of test our items. We actually adapted items from the breakfast survey. And then we did our national survey last year, and that data is being analyzed. This is some of our preliminary results that we just reported in our annual report. But you can see that the USPSTF 2014 was 32%. In 2022, we got about 29%. And then for the 2021, went up to 37%. NCCN guidelines, which are much more expanded and kind of loose criteria, we're 54%. And the PLCO risk model is probably the most commonly used risk model for lung cancer screening throughout the world. And we used the threshold that's commonly used, the 1.5, and found that 51% of age-appropriate veterans were eligible for lung cancer screening using that risk model.
So I think this slide brings up a couple interesting points. One, we identified problems as we were going along, and we have come up with sort of creative ways to address them, which I think is something that happens in research a lot, right? Like you go down the road thinking, or in evaluation, you go down the road thinking you're going to do it one way, you encounter a problem and you can either kind of throw your hands up in the air and stop, or you can think of ways to address it, recognizing that other people are probably facing the same questions. And so this, I think this is, this was a nice way to address that, I thought. Another thing was doing this in-person pilot in Nashville, and this was became a bit of a theme for how we've moved forward with work. We have a great opportunity here where we have a local VA that we look at and recognize it's not the same as all the other VAs, but it gives us the opportunity to work with our local team to maybe pilot some things in person, see how veterans might answer certain questions that they might have trouble with. Same thing for providers if we're doing surveys or interviews, to pilot them here, tune things up a little bit better rather than just distributing the whole survey nationwide and then realizing that there's a couple questions that we can't really use the data for because they really were unanswerable questions.
Yeah, it was very helpful, especially getting smoking histories is challenging, and there's lots of ways to do it. So moving into effectiveness, it's obviously very important that we report rates of screen detected lung cancer. So that's what we've been doing. We've gotten these data from the CDW as thoracic malignancies anytime after a screening, but we've also reported back veterans diagnosed with thoracic malignancies as reported by the program. And you can see here over 260 veterans screened by VA PALS programs were diagnosed with thoracic malignancy between January 2018 and September 30th to 2022. And so we've also looking at diagnostic testing, so how many PET scans, bronchoscopies, and then treatment, radiation, and thoracic surgery, as well as chemotherapy. And these variables we continue to work on, and these are kind of a work in progress, but we're finishing them up. So another challenge with not having the VA PALS LCAP system is we didn't have the data we had planned on for all the lung cancer data we were excited about getting. So we actually we looked into the possibility of doing chart reviews. We found that we could do it nationally. So we pivoted that project to start to do chart reviews to gather more information, validate those lung cancer diagnoses that were being reported by programs. So navigators gave us that information. And then we went and got more information, exact stage, clinical versus pathologic stage, histology, treatments received, and then we're also using the opportunity to validate other variables in our cohort. So this work is finishing up this month and we're super excited about it. Another area that I'm very excited about too is the tobacco treatment. We've been working with the national office and the VA for tobacco treatment, and we have many different types of outcomes that we've completed and are still in process of validating. But orders for tobacco treatment services, this could be referrals, this could be education, this could be medicines, but it really reflects the intention of providers, as well as information from the National Health Reminder, which reflects what was offered in a visit to a patient. And then what were the actual medication fills that the patient picked up. The stop codes, these are specific for the tobacco cessation programs. And reflects that a veteran actually showed up to an encounter at a program and had counseling and other services, medications offered. And then we're also gathering information on attitudes towards precision tobacco treatment with one of our tobacco treatment experts, and information on quit attempts through some of our veteran surveys that we're doing. And so the first survey is the Veteran Experience Survey. So this is an adapted patient satisfaction with cancer care scale. It's 18 items with Likert 1 to 5, which is depicted here on the right. We sent this to veterans who we believe were screened by programs. Because we didn't have the VA PALS LCAP system, we can't tell for sure, but most of the programs, the navigator actually orders the scan, and we can see that in the CDW. So we sent the survey to veterans who had an exam that was ordered by a navigator. Now, 2 programs didn't, so we had to work with them individually to figure out how we would find their veterans that were part of their program. But we did that, and we deployed the survey last summer through the fall, and where we could, we oversampled for rural veterans, at least 50%. So it was a mailed survey. And we sent 1 reminder if they didn't respond to the initial survey. And then we offered them $20 for completing the survey. And then we entered that data into REDCap. Our response rate was 31%. Of course, we'd like to see that higher. But overall, with a max score of 90, the weighted overall experience score was 71%. So pretty good. They have pretty good experience. And it really didn't vary rural versus non-rural. So interesting data. And then we did a provider experience survey where we looked at feasibility, acceptability, appropriateness of lung cancer screening programs. And so these were the FIM, the AIM, the IM scales adapted for lung cancer screening programs with a Likert scale 1 to 5, depicted here on the right. And we sent this electronically through VA REDCap to primary care providers from August to October of last year. So it was a 12-week survey. They got weekly reminders. And then we offered a service line lunch to 3 sites with the highest response rates. And Still not the response rates we were hoping for, 29.2%, but with a max score of 20, seems like providers overall felt like VA PALS lung cancer screening programs were feasible, acceptable, and appropriate overall. So I will give it back to Lucy to go into some of our adoption measures.
Are there any questions now before we?
Perfect. This is Rebecca. I was just going to say, we have some questions in the chat and maybe we could just field a few of those. And then if any others come up before you go on, great presentation thus far. A couple of these questions, I think I'll wait till the end because I think there'll be kind of some global questions. Some of these questions you've also addressed to a certain extent, but I wanted to see if you wanted to say any more. So one of the questions here is, can you say more about recruitment, especially if it was through primary care or direct outreach, et cetera? So I think you did kind of cover this. If there was anything else you wanted to say about recruitment. Another question, going back to adoption and adoption challenges, is how much you think some of the adoption challenges have to do with the unintended consequences, such as risks of LDCT, for example.
And so great questions, and questions we ask ourselves and are asked a lot. So regarding recruitment, and this is interesting because each VA does it a little bit differently, right? Like the primary care teams really want to have ownership over most of the process, right? Like they want to kind of decide who's eligible. They want to have that discussion with the patient. They want to order the CT for them and sort of shepherd them through the process. Some are more like, we're so busy. If there's another team who can do most of these things, we're happy to make the referral and then have you take ownership of almost everything else that happens. Just let us know what else you need us to do. And so we kind of see two different models that emerge from that.
Yeah, and this will come up a little bit more detail in our process maps project. But most of the sites were referral based, and they could come from any provider referred into the program. But we did have 2 that did direct outreach.
And the other question regarding, could adoption be related to maybe some of the perceived risks of LDCT? I think absolutely. I think from the patient perspective and the provider perspective. And so a big part of our initial work was, just talking about LDCT and who it's appropriate for and what are the real risks or what are the real benefits or what are some of the myths. And so that was initially in Nashville, we had a grand rounds with the primary care team. So we could bring an expert in, we could talk about it, we could try to address any of those. But yes, I think, yes, that definitely
Plays into it. Yeah.
All right. So to move on to adoption, and again, if anyone has any questions, feel free to ask along the way. All right. So when we started looking at adoption, we looked across the sites, and this is actually an area where we would love to have some feedback on, because we had some trouble deciding what fit more into adoption, sort of the willingness to participate, and what fit more into fidelity, what was actually done and was it done the right way. And some of this stemmed from when the program was designed, nobody discreetly said, you have to do this and you have to do that and you have to do that. So defining the fidelity points was a little bit tricky. And so we kind of picked some of them. So it was the big highlights were, did you hire a navigator? Did you implement the LCAP system as intended? Did you run the CT phantoms as intended to? And so those are sort of the more fidelity measures, while the adoption measures are what actual numbers of people did these things and did it look different across the different sites. And so at the site level, here are all the different sites that were in VA PALS, and talking about usage of the LCAP system. Well, the LCAP system unfortunately never really gained traction and got off the ground. So really the only place that used it was Phoenix for the pilot testing. When we look at the different types of people who were involved at the different programs and who were willing to participate, these are the different sites and the different types of providers and staff who participated in the programs and were willing to participate in the program.
And that started the programs.
And and this to me is really one of the key components, this navigators. Did you intend to hire a navigator? Were you willing to hire a navigator? Did you actually hire a navigator? How long did it take to do that? did your navigator complete the training that was offered to them? And sort of what did their work status look like? So everyone did hire a navigator. And what we think is one of the greatest highlights of the program is not only did they hire a navigator during that initial 2-year funding period, but eventually every site that was involved in this program made this a permanent position that the VA itself paid for. So I think that's one of the big successes of the program. And then the phantom data, and this is in how CT sort of quality assurance is done. It's basically this structure that you put onto a CT scanner. The scanner scans it, and then you can see what the image quality looks like, and if it's good image quality, bad image quality, and how you might want to tweak your parameters to make the image quality better. So this is showing the sites that used the phantoms, submitted the data, and whether they tried to improve their image quality based on that. This is looking at the types of providers by different sites that ordered the low-dose CT for lung cancer screening. And so this is one of those questions of like, who's doing it across the sites? How does it look different? So is it a physician ordering the lung cancer screening? Is it an advanced practice provider? Is it a primary care individual? Is it someone from a different subspecialty? And so there is variability by how sites were doing things, and that looks a little bit to that recruitment question that we had earlier. So different sites were doing things differently. We also looked at organizational readiness and readiness for lung cancer screening. This was something that, again, we piloted at the Nashville VA, and we found that in Nashville, radiologists were more ready for lung screening than primary care. And when we talked to some of our sort of organizational experts, they said, or organizational readiness experts, they said, this is not surprising. Generally, people who are a little more subspecialized in one area might have a little more readiness for it. We found that our leaders were more ready than our non-leaders. And we also found that our leaders sort of embraced this change more than the non-leaders, had a higher change valence for it. So we piloted in Nashville, and then we distributed a larger survey across all of the VA PAL sites, because when we did this pilot and submitted our work to journals and presented it, one of the biggest questions we always got was like, that's great, you looked at organizational readiness, but like, what does that mean? And so this was another one of those times where we said, okay, I guess we can try to figure out what it means. And so we distributed a survey across all of the sites to assess organizational readiness, and then tied that to an outcome of actual utilization of lung cancer screening. And what we found was that sites that had higher organizational readiness for lung screening were actually doing more lung screening. And so we thought, if you're going to be implementing this at a new site, you might want to increase readiness by increasing awareness, offering education, and things like that. And we found that trend persisted across the 2 subscales of the readiness score that we used, and with change valence. All right, on to implementation. Or any questions before we move on to implementation? I know we're gonna be near.
Yes, there are a lot of great questions. I don't know how we're gonna get through all these. So I'll just chime in with a couple for now. So some kudos, great and amazing work. Wondering how this would look like in a low resource setting. How would you recommend this program to be adopted in LMICs? And it says greetings from Zambia.
So that's part of our future directions, really. So great question. And one thing we're really working on right now, and we're excited because I think it's really moving forward, is mobile lung screening and bringing lung screening to our patients instead of having the veterans have to come to the hubs for lung screening. And so this has been a great project run by some of the people through the LPOP initiative, and we're almost there.
Yeah, we're looking forward to evaluating in different settings, especially the rural setting, and doing mobile CT screening.
Excellent. Another question here. Can you tie the feasibility, acceptability, and appropriateness measures to adoption and or maintenance?
We've thought about this. And we would love some input and feedback.
Or if anyone knows of examples of how that has been done, we would love to hear more about it, because we haven't quite figured it out yet, but we would love to.
Other than saying generally, it seems like providers think that it's feasible, appropriate, and acceptable.
Great. Maybe that's something at the end, if we have some time, we could talk about a little bit more with an advisor who might have some experience in this. So let's do one more question and then we'll let you continue. Are there any data on the frequency of percentage of people who came back for annual repeated lung cancer screening?
We do
You have the
have,
rurality data.
we have the rurality data. We have, I did an interrupted time series analysis, didn't present it here, but we do look at the annual repeats in that study. And it increased, and that was just among the demonstration project VAs. So I don't have it nationally actually, but people have looked at it, yes. And the VA is actually higher. I think it was like around 60–70%, I want to say. But I remember it definitely being higher than other healthcare systems.
Which is an important component because it's not just having your initial screening study where the true value of lung cancer screening is. It's coming back year after year.
Yeah, great question.
Great. Okay.
Okay, so implementation. This is,
Yeah, let's go ahead and move on. So we have
This
about
is-
10 more
yeah,
minutes.
this is one of my favorite projects. One of our favorite projects was doing process maps. So we did interviews with navigators at all the sites initially, and then every year to kind of get an understanding of how they started their program and then how processes, delivery processes changed over time. And Thomas actually did a lot of work with us on this project. So these are some of the examples of the process maps that we created from those interviews. Indianapolis, as you can see here, it's a referral base, but Phoenix was the program reached out. So we collected information on patient identification, how they did their eligibility confirmation, smoking cessation, shared decision-making, appointment scheduling, and communication of results back to veterans. And this is what we found at baseline. So most of them were referral based, 7 out of 9 here. And then most of the shared decision-making that's required, that was done by telephone only at most of the sites, but some did have in person, and some people did it both ways, in person and by telephone. And then tobacco cessation, mostly this was done by programs offering nicotine replacement therapy by the navigator. Veterans that were interested in the tobacco cessation program got referred there by the navigator, but the navigator would refer back to the primary care for Chantix, for other medications. For scheduling, I didn't expect this to be so difficult, but it was, but most of the scheduling was handled by radiology for the actual screening exams. But we have a lot of challenges with scheduling, so this is actually interesting to me. And then communication of results to veterans. So most of the programs did telephone and/or letters for all results. It didn't matter what the results were. But then 4 programs did letters for negative screens, but then they called the veterans with any abnormal screening results. So then we used the framework to look at process adaptations over time. We did a total of 20 interviews with 14 different navigators, 1 year after baseline and then 2 years after baseline. 7 programs were operational from 2019 to 2020, and just a few adaptations, mostly in response to the pandemic during that time period. But in year 2, when all 10 programs were operational, they all had navigators doing lung cancer screening. There were 14 adaptations that were planned and unplanned, and often due to increased workload of the navigators. Most of this around the processes of identification and confirmation of eligibility. And then also how they were communicating results back. And then we also, because data management and tracking is so important in lung cancer screening programs, we actually asked programs how they did this over time in their program. And we had adaptations in 6 out of the 10 programs. And this paper is just recently published. We also did interviews on barriers and facilitators of implementing lung cancer screening programs. So these were interviews conducted from December 2020 to September 2021. There were 30 telephone interviews with radiology and primary care staff and providers, but also the program directors at each of the sites. And this figure here is our framework for the themes that have been found for these interviews. And so I was going to share some of these themes with you today. The first one is, I would say, Vietnam era, and a little bit after that seemed to have a little bit more mistrust, speaking to patient psychology as one of the themes. The idea is to train a nurse practitioners so that they can take care of almost everything on a day-to-day basis, referring to protocols and processes of how lung cancer screening programs were thought to be and developed. And And then this one on VA PALS was a great opportunity for us. It really was the catalyst to bring all this together, make it happen. We learned from each other. So speaking to institutional networks and how they work together and learn from each other. This one on, we had challenges, I think, even getting buy-in for the position, speaking to funding. And this one would come up in our leadership calls a lot. And the VA PALS leadership team actually worked with each site to help them build their leadership buy-in so that they could transition those navigators from temporary 2-year positions to permanent positions. So that was a major priority. So then primary care has been kind of mixed, not that they don't believe in it, I think, but just that I think they're very busy and it's been hard to find advocates in primary care. So speaking of how important it is to have teamwork in building these programs, and especially in primary care. And then this one I think was really interesting because we did interview radiologists, and I haven't heard this come up before, but it's not purely just looking for a nodule. There really is a line of judgment that has to go into it when you're reading these scans, even though we have protocols and processes for doing it, still has a level of judgment. And the last one here, the whole issue of appropriate resources and appropriate tracking mechanism is really big, especially for our sister facilities and smaller facilities that are in more rural areas. So tracking is super important to make sure that you're keeping track of the annual screens, because that's really when the lung cancers are diagnosed. They're diagnosed on those annual follow-up screenings. And then we also really try to get at perspectives of barriers and facilitators at the rural level in the rural setting. So maintenance, how are we doing on time? Okay.
We
Okay.
are actually,
Yeah.
we
So,
are actually just about to run out of time. So we are happy to make the papers and the slides available so that we can spend our final 3 minutes addressing
Sure.
some of the great questions and getting some of your thoughts. I know you have some great slides about future directions. So maybe if you want to share this, and then we'll address some of the questions and continue the dialogue. Thank you so much.
Yeah, so we are really excited and want to start exploring and developing novel strategies to increase lung cancer screening among veterans in diverse settings. We've kind of already talked about this. Our next project, we're going to be working with our mobile unit that we've gotten in our VISN, and also collaborators in in Charleston to look at CT lung screening and how to evaluate that. So that's really exciting. Lucy's kind of an expert in the patient level work. And I've done a lot of work in provider level lung cancer screening strategies, attitudes, knowledge. So we're hoping to put this together into a multi-level intervention. And then of course we need to evaluate that intervention. So we're really excited to continue our work in evaluation and want to grow in that area.
That's awesome. We have a great question here about, for you, what is the key question that you have for us as a group?
I would say the adoption versus implementation measures.
Does anyone want to?
Or fidelity, I guess it would be.
And so so that's always a really good question. And I think the way that we have gone about it in our work is that if any aspect of implementation begins, it's been adopted. And then anything thereafter is the degree to which it's been implemented. And so then that would be implementation. So that's the quick 1-minute answer.
Great, Paul. We also had a question about thinking about representativeness and equity at the different levels. Is that something that you could address quickly?
From the lens of representatives, of making sure the veterans that we are reaching is equitable. And so we've tried. One, we were funded partially by the Office of Rural Health. So we really tried to focus a lot of our outcome measures to make sure that we were appropriately capturing and reaching that population. Where we're able to, we have tried to oversample for rural veterans and other historically underrepresented or underserved groups in our surveys and interviews and such. And then we've tried in our sort of outreach efforts and our future planning efforts to develop strategies that are specifically trying to reach those who may not have as much access.
Excellent. I know we only have about a minute left. Russ had a question. Russ, I don't know if you want to add it, but I'm thinking about exploring the links between FIT, AIM, et cetera, related to the REAIM outcomes and also to the CFIR factors. To the REAIM outcomes could be informative. So going back to your question for us, that might be something to think about and explore in your future directions for your research. Were there any, I think we're almost at time, Samantha, any last minute questions? I know this hour went really, really fast. This was so informative and so much information. There were a lot of great questions in the chat. So we can share the chat with you, Lucy and Jennifer, so that you can think a little bit more about some of the ideas that were posed. And certainly if there are any questions for our team, or if we have questions for you, we can follow up and we'll provide the slides as well as the recording for everyone to go back to.
That would be great. I'm looking through the chat now, but if you could send it to us, there's a lot of
Yeah, that would be great.
stuff here.
Thank you.
Really appreciate all
Yes,
of your
Thank
time.
you so much for the excellent presentation, and we really appreciate your time today. And thank you everyone for joining us. I think this was a great hour, and lots more questions and conversations that can happen offline.
Yes, and I'll just
Thank
close
you.
with, it takes so much work to address all 5 dimensions, as we saw.
does.
So if you
Yeah,
are
8 different
hanging tight
projects.
to the maintenance, we will definitely share the slides and all of the great papers. So it's just, thank you so much for the work, and we'll share more to come. Thank you.
Thank you for
Thanks.
having us.
Take care. Thank you.